Coming back to problems of late adulthood, thought I would break this up into two separate ones. Right? So late adulthood is those over 65. So from 65 to death. Right? Aging is replacing physical maturity. Outlook is changing and it's going from deep satisfaction and happiness to despair and sadness, depending on where they are. Science, medical, technology mean people are living longer and for the most part having better lives as they get older. Went over a bunch of facts and myths, right? Myths, most elders live in the nursing home. No, most people live at home, right? More than 50% of those over 65 are still living at home with the spouse or maintaining a household alone. More than most between 65 are going to fall between the millionaires and the 12% of older adults who live in poverty. Other cultures, when compared to America, are going to place older adults in higher esteem and actually value their wisdom and experience. In America, we tend to push the elderly to a corner and forget about them. Physical changes. It says that physical changes of aging are not noticeable until the late 30s. I don't know. Pretty certain I started getting the occasional gray beforehand. Harder to stand up and move in the morning. But a bunch of things are going to come into play. Right? Genetics, early physical health care. If you go to the doctor regularly, if you're staying on top of your health, eating right, exercising, right? What are you doing currently? Have you been getting mental health care? Do you have a more positive attitude, right? That's going to affect the aging process. Developmental stage, we're going to look at integrity, a state of wholeness. Is someone going to, accept who they are and their contributions? Are they going to be able to find order and meaning in their life? If they can't get to that sense of integrity or state of integrity or the sense of wholeness, their life will be filled with despair. Aging is no longer considered a natural decline in health and abilities, right? We learned today the brain is neuroplastic. It can grow and it can change and rewire and get new pathways. Regular physical, mental exercise lowers your risk of developing dementia. Socializing with others, right? Remaining active has both physical and psychological benefits. Physical adaptations, right? Aerobic activity, muscle strengthening prevents physical problems. Osteoporosis is a big one in females. Physical body, you have a good physical body, you're more likely to have a good psychosocial body, so mental health process. Physical problems can lead to changes in mental status. You get sick, you develop cancer, you're struggling physically, and that's going to affect your mental health, right? Individuals who live alone tend to neglect their nutritional needs. Sexuality remains important for many older adults. Sex is at the bottom of Maslow's hierarchy. Most older Americans get their benefits through Medicare and Medicaid, and sometimes, actually a lot of times, they can't afford those healthcare needs, so they put them in the background. HIV and AIDS is emerging among older adults, and we're having to figure out the long-term effects sometimes of these diseases, because initially individuals, right, when HIV just came around in the 80s, initially it was a death sentence. Now, due to medications, people are just living longer. Psychosocial adaptation, growing has become more impersonal. There's lots of problems that the elderly are going to be struggling with: money, food, housing, healthcare, right? Economics, especially nowadays. How do you afford to live? Financial problems leads to depression, anxiety, and paranoia, right? We have to be sensitive when we're talking to elderly. Sit down, give them time, because this is not something they're necessarily going to want to talk to us about. Housing, too much house or no house at all? Do they live in the old family home and they can't get around it and can't keep it up? There's independent living centers, life contract facilities, foster homes, subsidized housings, assisted living situations, all sorts of places. Loss and death. Right? Loss and death. Many older adults are going to lose people around them. Siblings, family members, their parents, maybe even a child, depending on how old they went. After your spouse dies, right, depression might become common. Especially the older generation, someone's been married 60 years and their spouse dies. What do? We have to help them form connections with other individuals. Abuse, right? Polypharmacy, use of 5 or more medications a day, We need to teach older adults, and we need to assess what they're using. We have to refer to medications by name, provide written instructions, right? Don't just say, take this pink pill. Say, hey, you're going to take 50 milligrams of diphenhydramine before bedtime, right? We have to let them ask the questions when they have them because they might not remember, right? Have an active discussion and take the time. It might take longer, right? Because of sight and memory, it could contribute to misuse of medications. They might forget that they took their medications and all of a sudden they're taking 2 sets of their blood pressure medications. They're also going to metabolize and excrete drugs more slowly, so they're going to be more sensitive to drugs. But are they also on unnecessary or excessive medications? They might have more than one physician, so they need to, have that weekly medication box. They need to take it to each doctor's appointment, bring their pill bottles with them. Talk to their pharmacist, right? We need to make sure they're using their medications correctly. Those over 65 have the same mental health disorders, right? We're not going to see schizophrenia start at 65. However, if they had schizophrenia when they're younger, they're still going to have it at 65. But now you throw in more vulnerability, abuse, memory, dementia, Alzheimer's, right? Elder abuse, any action that takes advantage of an older person or his or her well-being or property. Older adults without support are more vulnerable to assault or attack by others. It could be family members or caregivers, right? Family members just might be tired of the responsibility and they just might lose control. They get frustrated. The typical abused elder has physical and mental problems and is living with a relative. Different types of elder abuse, abandonment. Grandma can't get out of bed. I'm just going to go on a 3-week vacation and she can figure it out on her own, right? Exploitation is especially financial. Grandma's not going to use her money. Let me just use it for her. I need this new car, so I'm just going to go into Grandma's checking account, take the money, and buy myself a car. Neglect, not making sure not taking them to the doctor when they need to, not buying them new clothes or shelter, not giving them food or drink, right? Physical abuse, you get frustrated and you slap grandma. Psychological abuse, oh my God, grandma, I can't believe you just peed yourself again. Why are you acting like such a child? I don't want to deal with this. And then you just leave her alone. Grandma, if you don't stop this, we're going to put you in a nursing home. Self-neglect. Sometimes when you add in depression, elderly neglect themselves, right? They just might not eat. They might not take care of themselves. They might not go to the doctor. They might not feel a need to. Sexual abuse, even in the elderly, right? Nursing homes. Violation of rights, right? And that includes the right to consent for medical treatment. Maybe the patient's like, hey, look, I don't want to carry on. I don't want to do this chemo for breast cancer, lung cancer. It's advanced. It's like, stage 4, it's metastasized. I don't want to do it. And the family says, grandma, we don't care what you say. You're going to go have chemo and surgery. That's a violation of grandma's rights. Depression, most common mental health disorder in late adulthood, right? And a lot of times it's underdiagnosed and not treated because they don't want to talk about it. We have to assess for behaviors that signal the onset of depression, and a lot of times they go hand in hand with dementia. Changes in appetite, slowed memory, fatigue, withdrawal, hopelessness, right? It's treated via therapy as well as medications, and sometimes just sitting and talking to them. Sit and have a conversation, right? These are more of those signs and symptoms, again, of depression in the older adult. And again, I don't know why these are over here all like, look, we have this 3 times. Signs and symptoms of depression, difficulty with ADLs, changes in appetite, low energy, withdrawal, feeling hopeless, right? Anhedonia, increased anxiety, lack of interest. Depression is treated with group and medication. Reminiscence or validation therapy, talk with them about what's going on, right? Antidepressants have the fewer side effects and are generally, again, going to be our first line, but also provide emotional support and interest. Just talk to them. Standards of geriatric care, right? These exist. They were developed by the ANA. It's what we're supposed to do, right? Caregivers have a responsibility to treat older adults with respect, kindness, and sensitivity. Age-related interventions, right? Normal process of aging slows the older adult's mental and physical function. We don't want to overload the patient with information. We want to go at their pace. Music therapy, Assess for physical sensory changes that can affect learning. Can they not read? Is their hearing going? We want to break a task into smaller steps and be patient if it takes them longer. Mentally ill older adults need to stick with a stable environment and daily routine. They can continue to function into old age, right? But you do see a decrease in intellectual function in adults, especially with mental illness, right? Again, with every age group, we say this: early detection of mental health problems is key, right? Improved diets and increased physical activity need to all around better outcomes. Doll therapy, never really heard about that, carrying that doll around, right? Cognitive impairment, Alzheimer's disease, and dementia. So cognition, right? Frontal lobe. Disruption in higher brain function that results in confusion. So there are normal changes in cognition. As we grow older, our response time and our short-term memory become impaired. We need more time to process and store information and maybe to remember things. But confusion itself is not normal. And any sudden changes, especially one with confusion, we need to investigate it. I have learned this should be the 6 Ds of confusion: damage, delirium, dementia, depression, deprivation, and drugs. Right? Those are things that can all cause confusion. So medications. Many medications can cause confusion because drugs are eliminated slowly and the metabolism is slower. Confusion is also the first sign. We have to be careful providing psychotropic drugs. But it's not just psychotropic drugs. Allergies, arthritis, high blood pressure, IBS, migraines, headaches, pains, Parkinson's, antipsychotics, sedatives, hypnotics, OTC drugs, such as those used to treat cold, flu, diarrhea, hay fever, and insomnia, can cause confusion. So we have to be cautious with any medication in the elderly. Go slow and low, right? We're going to start with a low dose and slowly increase it. Delirium, it's a quick change in consciousness, right? It can result in delusions or hallucinations. If we treat it early, it's reversible, and we expect a full recovery, right? If we find that cause and treat it. We have to recognize the signs of delirium and treat the source. So sometimes we get delirium from a medication, psychoactive substances, chemicals, alcohol, right? A head injury, a UTI. So we have to treat that underlying cause first, right? So if you see new delusions or hallucinations in an elderly, it is not schizophrenia. Schizophrenia, right, does not start in someone over 60, right? And we also have to remember there are things we as nurses can do to help someone with delirium, right? If they're in a hospital, we don't want to keep the lights on 24/7 and the TV on. We want to put the lights on during the day, turn them off and dim them in the evening, turn the TV off, right? We want to monitor their level of consciousness. We want to use clocks and calendars, especially with delirium, to help reorient them to the day. We want to encourage fluids because they might not be drinking. We want to prevent dehydration. It is not chronic and progressive delirium. We have to remember those differences when we talk about what is delirium and what is dementia. So dementia is a loss of multiple abilities: memory, language, ability to think and understand. It's chronic, it comes on slowly, and is usually irreversible. A lot of times we overlook it because we're so focused on other things, right? There's a bunch of different types of dementia. Alzheimer's being the one we're most familiar with. Vascular, Lewy body, frontotemporal. I want to say it was Bruce Willis, frontotemporal dementia was just diagnosed. And I want to say Robin Williams had Lewy body dementia. So they come on and it's hard to deal with, right? In dementia, individuals are unable to process new information. They lose the ability to retrieve and use that information. And the most common symptom is a declining memory. You get lost in your own neighborhood, right? I know I enter a room and forget why I'm there, and then I get 100 times distracted, but this is more pronounced. Sundown syndrome, right? Confusion, agitation, disruptive actions that occur in late afternoon or evening. So Alzheimer's disease, progressive degenerative disorder that affects brain cells and memory, right? So you're going to have impaired memory, thinking, and behavior. There's two categories: early onset, before 65. I like Go Ask Alice. I think at least the book is a good representation. I've never seen the movie. Or late onset, right? This is not a normal part of aging. It's a slow process that robs an individual of their personhood. And each decline is accompanied by a loss. There is no cure. We have to let family members know, there are meds and they can slow down the process. And we need to talk about the side effects of the medications. We have to talk about anticipatory grief and loss. And we have to talk about caregiver role strain, because these family members are going to be more at risk for caregiver role strain. Right? Alzheimer's disease is a gradual progressive death of one's own brain and function. And honestly, even an individual who's diagnosed with Alzheimer's in the beginning, when they still are more aware in the early stages, they can have anticipatory grief for themselves. And then the family members can have anticipatory grief because they know grandma's there and they know grandma's going to slowly slip away. So early stage, you have a loss of more recent memory. They might be able to tell you everything that happened in 1950, but they might not remember what they had for breakfast today or how to get home. They struggle to process new information and retain new information, and you start to see some language problems, right? Early stage is the best stage to start medication therapy because it slows the progression. It keeps them in that early stage for longer, but they will progress to the intermediate stage. And then the severe stage, inability to do anything. And then end stage Alzheimer's is coma and death. They lose the ability to swallow. They forget how to eat. Therapeutic care for Alzheimer's has 3 goals: safety and well-being. Safety and well-being will always be one, like number one, right? Are they eating? Are they drinking? Are they eliminating? Right? Are they not wandering out into the street and getting lost? Manage clients' behaviors therapeutically, right? How do you manage sundowners if they start to get aggressive at night? A lot of times, though not recommended, we use antipsychotics because it works well. But we also have to provide support to family, relatives, and caregivers because they're going to be struggling with the grief, right? That anticipatory grief of what's happening to their loved one, but then also the strain of now being a caregiver, and they might not have ever planned to be a caregiver. When behaving inappropriately, clients are redirected to less stressful activities. So if you have a client, let's say they used to love knitting and they're trying to knit and they're getting frustrated, let's move them to napkin folding, right? It sounds silly, but we want to give them less stressful things. If they used to always do a crossword puzzle every day and they could do the New York Times crossword puzzle in ink, and they're getting frustrated as they get older, right? Find an easier crossword puzzle for them to do or do it with them. If you have a client, right, we did the unfolding case study about the Alzheimer's patient who kind of just wandered away. If you have an Alzheimer's patient who's wandering in a long-term care facility, right, redirect them. Hey, you know what? I just heard we have this juice in the kitchen. Let's go get a juice, and redirect them into a different direction with something that they would like to do. Need-driven dementia compromised behavior model. Offensive behaviors are communications of unmet needs. The ability to communicate is taken away from an individual with Alzheimer's. So just like in pediatric patients, when we talked about like toddlers and their temper tantrums, right? We all know toddlers don't yet have developed language skills. They don't know how to communicate some things. So toddlers then have temper tantrums. So the same thing. A lot of times when you have these offensive behaviors in an individual with Alzheimer's and dementia, it's because something's going on in the background, something changed, there's an environmental trigger, and they don't know how to communicate it with us anymore. So we have to assess if there is an offensive behavior, what is going on, and respond in a way to meet that need and decrease inappropriate behaviors. Right? So when I worked with that old patient with Alzheimer's, I looked just like his wife, and he'd see me, he'd be like, honey, 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 and he would try to pull me in and give me a kiss, right? He thought I looked like her, so I'd be like, here, let's hold my hand instead, and that way we can both meet, and I would pull a little bit away, but still maintain a physical contact in a nice, appropriate, within the realms and bounds of my role, therapeutic way. You have to provide the caregiver support. Elder abuse, especially for those with Alzheimer's, is huge. Right? Most individuals are cared for in their home by family, friends, or home care agencies. And home care agencies, right, a lot of them may not even be CNAs. It's just someone who walks off the street, right? I did that in nursing school. I worked for a home care agency. I was not a CNA. I had zero training. They are at high risk for abusing individuals because they just get stressed out and burnt out. There's informal support groups, getting family members together, getting family members with friends, any type of social group. And then there's formal support groups. If you have a family and they are providing 100% total support for grandma, bring in a home care agency for respite care. Or if an individual is still more functional, take them to an elder care center. Or, right, we're going to talk about death and dying nest, look into hospice and find out what you can do. When caregivers are educated on the disease process, on what to expect and what they can do as long as support that's available for them, stress levels in the home decrease. This is the end of the elderly. If y'all have any questions, let me know.